call upon Dr. Roohi M to talk on Anisocoria. She's from Comcast Eye Hospital, Calicut.
A very good morning to one and all present here. Thank you, Dr. Laila ma'am and AIOS for this wonderful opportunity. I would like to speak on an approach to anisocoria. Anisocoria, in layman's term, means the presence of difference in the size of the right and the left pupils. It is a sign of an abnormality in the efferent pathway. If you suspect anisocoria, first step is to take a thorough history. And the second step is to ask the following questions to yourself. First question is there anisocoria? And the second, is the smaller or the larger pupil abnormal? First of all, what is the normal pupil size? It is up to from 2 to 6 mm. Ordinarily, we see 3 to 4 mm diameter. Physiological anisocoria, there is about 1 mm difference in up to 15 to 20% of the normal population. A difference of 2 mm is considered significant. This is the parasympathetic pathway, as you all know. It is usually affected in third cranial nerve palsy, tonic pupil, and uncal herniation. Sympathetic pathway, as you all know, this is the pathway, you all already know about it. It is affected in Horner syndrome and pontine hemorrhage, to name a few. So the near response is an interplay between convergence, accommodation, and meiosis. First and foremost, take a history, as was clearly pointed out by all of these eminent experts. Blurring, amaurosis, double vision, headache, numbness, face, neck, arm pain, a trauma or surgery, exposure to toxins or drugs, systemic diseases, and most importantly, old photos need to be checked. A thorough visual examination of visual acuity, color vision, lid, proptosis, extraocular movements, visual field analysis, at least a confrontation test, cranial nerve examination, and of course check for superficial temporal arteries in the hands, necks. So a pupil examination, we can use a pupil gauge to measure. We need to check the size of the pupil in light, in ambient light and in dark. We need to check size of pupil after about 20 minutes of sitting in a dark room, called the dark adaptation time, and then in a wet lit room. Check the light reflex, the near reflex, and swinging flashlight test is a must. So this is the algorithm. I will take you through each of this, but in general, if the pupil size is equal, check for RAPD, and if there is anisocoria, check for physiological, or if it is pathological, check if there is any damage to the iris, if there is any sympathetic or parasympathetic defect. So these are the causes of a large and a small pupil. You all know it already. Anisocoria is physiological, as you all know. But what is important is there is good reaction to light and dark. The lids and extraocular movements are normal and may change size and side. So anisocoria, we need to check if it is worse in darkness or similar in dark and light, or worse in light. This is the basic algorithm that I'll take you through each case. The first case, a 27-year-old male, he presented with headache and a blurring of vision. The right eye pupil, as you can see, there is a difference in the size of the pupils between the right and the left eye. This was the left eye. As you can see, a vermiform movement of the iris. So let us take you through. Do both the pupils constrict to light? They did not. So was the larger pupil abnormal? Was there ptosis or abnormal extraocular movements? There was not. So was there vermiform movement? Yes. So we can consider if it is AD stonic pupil. So we tested with pilocarpine 0.125% and there was constriction of pupil. So we gave a provisional diagnosis of an AD stonic pupil. The second case, a 24-year-old female with history of RTA, road traffic accident, 3 days back. She had a complaint of diplopia. On examination, she had adduction and depression limitation, and the pupil was dilated in the left eye. I hope it is clear in the image. So here we checked again, was the larger pupil abnormal? If yes, then there was ptosis and abnormal extraocular movement. And so we consider a third nerve palsy. An MRI was suggestive of a diffuse axonal injury of the left side, and other clinical symptoms pointed to a diagnosis of an incomplete third nerve palsy. The third case presented with ptosis, meiosis, and anhidrosis. This is a video taken from the web. As you can see, there is a dilatation lag along with meiosis and an anisocoria more than 2 mm. In some cases, there is difference in eye color, difference in pupil size, or impaired facial flushing. 1% apraclonidine test, we can see there is lid retraction with dilatation of pupil on the affected side. These signs, along with other signs of Horner syndrome, give us a diagnosis of Horner syndrome. Theoretically, we also need to know about the effect of cocaine. So, cocaine, on instilling 2 drops of cocaine, 4% and 10%, in each eye, 5 minutes apart, and then measuring the degree of anisocoria. A post-cocaine anisocoria of 1 mm or greater is diagnostic of Horner syndrome on the side of the smaller pupil. Another case that we see in our clinic is light near dissociation, called Argyll-Robertson pupil. We see that the size of the pupil is smaller. Then the light reflex is absent in this case. But when we ask the patient to converge, the near reflex was present. This was a 16-year-old male who presented with headache. There was also convergence retraction syndrome in the nystagmus, if you could note. This is the etiology: afferent or efferent pathway lesion, or a dorsal midbrain syndrome, pineal tumor, or Wernicke's encephalopathy. An MRI of this 16-year-old boy revealed a pineal gland tumor, as you can see here, marked in orange. Another case, he had a history, 28-year-old male with a history of road traffic accident a few months back. On attempted adduction, there was globe elevation, upper lid retraction, and synkinetic meiosis. The pupil is not very clear. So basically, it was an aberrant regeneration case. The take-home message is, it is a non-invasive examination, so it should be an integral part of each and every ophthalmic investigation. It is truly a window to diagnosis. We need to use a stepwise method with which we are comfortable, and a careful history will give you important clues to the etiology. Thank you.
Thank you, Dr. Roohi. Thank you, Muscati sir, for being with us and giving us the valuable feedback. Thank you, sir.